चालू करूत सर. हॅलो.
कृष्ण चालू कर.
Okay.
हा.
Good evening, all of you. Today's my topic is cancer pain management. Definition of pain is an unpleasant sensory and emotional experience associated with actual and potential tissue damage or described in terms of such damage. Pain is always subjective. It is a definition given by the International Association for the Study of the Pain. What you can expect from the pain physician in any pain patients. Pain physician is a valuable resource in pain physiology, pharmacology, and providing additional treatment. Not only intervention, thorough assessment of patient management of all types of pain, adjustment of doses and side effects. There are two types of pain in cancer. One is a nociceptive pain, another is a neuropathic pain. Nociceptive pain results from the mechanical, thermal, or chemical excitation of the nociceptors. It is widely distributed in skin, subcutaneous tissue, bone, muscle, connective tissue, vasculature, and viscera. Experienced as an aching or throbbing pain. Sometimes it is a sharp feeling of pain. These nociceptive pain are opioid responsive. Another type of pain is a neuropathic pain which results from actual damage or irritation of a nerve or altered function of a nerve. It may be mediated by N-methyl D-aspartate, that is NMDA receptors. This pain described as a burning, tingling, shooting, electric-like sensations. It may be opioid resistant or may require higher doses of opioids. What should pain physician should do when any pain patient will come to their OPD? He should first ask a history of pain. Means how did the pain begin, localization of and its temporal characteristics, like does it have a periodicity, early morning pain, evening pain, night pain, etc., etc., or whenever it comes, for how much duration it will be there, how is pain described, it exact words used by the patient which gives clue to the underlying etiology. Whenever patient describe their kind of pain, which kind of pain they are having, they give us a clue to get the diagnosis of the cause of pain. What improve the pain means sometimes some movement or some positions may improve the pain of the patients, that we should ask them what position or what activity will improve your pain and what types of therapies till now he have tried for relieving of that pain. And another thing is also what makes the pain worse, at what time the pain become worse, daytime, night time, or which activity, walking, sitting, sleeping, whatever, and what is the impact of this pain on his daily routine life. These things should be asked by the pain physician. After that, how it assess the intensity of the pain. There are three scales which are commonly used for assessing the intensity of the pain. First is the visual analog scale, another one is the numerical scale, third one is the categorical scale. Most commonly used the visual analog scale, in which there is a 0 to 10 scoring is there. 0 is no pain, 1, 2, 3, 4, 5, 6, that's the increasing type of pain. Basis of pain in cancer. 65% pain in cancer patient are due to the tumor involvement of organic structure. Which organic structure? Like viscera, bone, or neural tissue. And 25% of pain is due to the cancer therapy. It may be due to the radiotherapy, it may be due to chemotherapy, or post-surgical pain syndrome, means post-thoracotomy or post-mastectomy. There are so many patients after CA breast come after mastectomy for pain in upper limb or chest pain. There are specific cancer pain syndromes are there. Bony and organ mets. Bony and organ mets are mainly seen in carcinoma of prostate, thyroid, breast, lungs, and kidney. About 25% of patients with the bony mets experience pain. What is the mechanism of pain in such a patients? There is a mechanical compression of a periosteum or capsule due to tumor expansion. It is a cause of the pain. It is relieved by the palliative radiation. It may relieve. Another one is a chemical irritation like prostaglandin E2, cytokines. These are of nerve ending in the periosteum. Periosteal nerve endings are inflamed due to or irritated due to these chemical mediators. Because of that, patient getting pain, which is may be relieved with the help of steroids, NSAID. Sometimes because of compression, because of osteoporosis, patient get pathological fractures. Sometimes due to perineural invasion also patient get pain. 50% decalcification before the lesion seen on X-ray. When we have to the lesion should see on X-ray whenever there is a 50% decalcification is needed, and in such conditions we need bone scan, and CT will be the best option to diagnose such a decalcification of the bone. Another type of pain syndrome is the leptomeningeal mets. This seen in the lymphoma, leukemia, breast and lung malignancy. Presentation are similar to meningitis, raised intracranial pressure, and they are with a neurological deficit. They are having a poor prognosis, survival of 6 weeks without treatment, 6 months with treatment. In such patient we need investigation like MRI sequences, tutuated, CSF in which there is a raised protein, decreased glucose and increased cellular, just like a meningitic like picture. In such patient we can treat that patient by radiation therapy, intrathecal chemo, steroid for headache. Another one is the plexopathies, means so many times the cancer or tumors are compressing some nerve plexuses, and because of that the plexopathies occur, and radiating pain, patients are suffering from radiating pain in that distribution of the nerve. The most commonly head and neck carcinomas, Pankos syndrome resulting in a brachial plexopathy, lumbosacral plexopathy associated with a CA rectum, cervix and sarcoma. Other cancer associated are breast and lymphoma. Pain precedes neurological deficit by 6 to 9 months. Basically, pain is preceded before any neurological deficit occurs, 6 to 9 months before patient getting pain. And these such plexopathies can be treated with medicines like antiepileptics, tricyclic antidepressants, opioids. And if these patients are not relieved with the medicine, then we can go for interventions like intrathecal opioids. We can give clonidine also and zinconotide also. Treatment associated pain, like when patients are undergone chemotherapy, they are getting pain. What type of pain it is? Oral mucositis. It is because of doxorubicin, daunorubicin, dactinomycin, bleomycin, etoposide, 5-fluorouracil. These are within 1 to 2 weeks of treatment after chemo and radio. These are treated with topical local anesthetics and opioids. Sometimes patient may get polyneuropathy because of chemotherapy, just like vincalcolide, cisplatin, paclitaxel, docetaxel, androlabine, bortezomib. These are the chemotherapy drugs. Because of that, polyneuropathy may occur, which is treated by the tricyclic antidepressants, antiepileptics and opioids. Treatment associated with pain after post-surgical. Mastectomy, thoracotomy, RND, nephrectomy, amputations. These surgeries may cause pain. Incidence is 25 to 50% of such surgeries. Patient may get pain after surgery, and these are also treated by tricyclic antidepressant, antiepileptic, opioids. And if we have to do interventions, we may go for intrathecal opioids, spinal cord stimulation, peripheral nerve stimulation. Management of cancer pain. In medical management, a traditional concept WHO put forth in 1986, it may be by mouth, by the ladder, by the clock, individual to patient needs. In starting, when patient came with you, we should give non-opioids. With or without adjuvant, you can give. If still patient may do not get the relief, then and pain is increased, then we can add some weak opioids. Still pain persists, then we can add strong opioids and non-opioids. Cancer pain, the temporal patterns. What are the temporal patterns in cancer pain? Constant pain. It occurs round the clock, and its management should be do again round the clock. We should not give a SOS prescription to constant pain. We have to give a round the clock medicine to decrease this constant pain. Another type of pain is a breakthrough pain. This breakthrough pain may be incidental pain, it may be intermittent pain, or it may be at the end of the dose failure. Means as those we are taken morning dose and its effectivity is decreased after some 4 to 6 hour or 8 hour, whatever the duration of action of that drug. At that time patient may getting pain again. This is called breakthrough pain. Breakthrough pain is the incidental pain which relate to pain occurring during certain specific activity like eating, defecating, walking, socializing. It is a rapid onset, short duration of action before the inciting event. Another breakthrough pain is the intermittent pain. It may be unpredictable, occur spontaneously without any provoking factor. It may be a rapid onset, shorter duration drugs on SOS basis, and end of dose failure. It pain occurring consistently prior to the next scheduled dose of the drug. The management, it should be done by increasing the dose of the drug or increasing the frequency of drug administration. You can make it BD dose to TDS or QID, whatever agreed. Now the modified WHO ladder for medical management of pain. In starting, we should give non-opioid analgesic NSAID. After that, we can add weak opioids, then strong opioids. We can add transdermal patches also. And in lastly, if still patient are complaining of pain, we go for intervention procedures like nerve blocks, epidurals, PCA pump, tick block therapy, spinal stimulators. What are the newer concepts in WHO ladder? Introduction of a newer non-analgesic adjuvant, introduction of a fixed dose drug combinations, recognition of breakthrough pain and its proper management irrespective of weak or strong opioids. Leapfrog step 2 to 3 above depending upon the severity of pain. Introduction of the interventional procedures for pain relief. These are added by the WHO for the management of pain. What opioid? Which opioids we should use? There are weak opioids and strong opioids. In weak opioid there are codeine, dihydrocodeine, tramadols. I will not get in details of these drugs. In strong opioid, morphine, fentanyl, buprenorphine. There are so many adjuvant. Sometimes some analgesics are, some are non-analgesic. In analgesic there are clonidine, antidepressant, anticonvulsant, corticosteroid, NMDA blockers, sodium channel blockers. In non-analgesic there are biphosphonates, calcitonin, PTA channel lock, radiopharmaceuticals, hormonal therapy, octreotide, baclofen, etc. What are the indication of? I especially mention only whatever we are using in practice. That are only I have mentioned in these slides, not in details. Indication of transdermal fentanyl. Fentanyl is not the first choice for pain management. It should be used for a stable pain. Effective dose determined by a short acting opioid. Those patients who are having swallowing difficulties, alteration of drug, then those patients should give a fentanyl patches. Absorption of other intolerance to oral route. Some patients may get difficulty in absorption of the oral drugs, or they may not get, they are intolerant to take oral route because of some GI problems. In such patient, we should prefer the transdermal fentanyl patches. What are the contraindication of transdermal fentanyl? It is a expensive. We should not use for the acute pain. Should not use for unstable pain. If patient is having some skin problem, we should not use. If patient is having edema, still we should not use it. What are the interventional management for managing such kind of pain when our medical line of treatment is failed? There are conventional and advanced interventional management procedures are there. In conventional procedures, we should proceed with nerve blocks, peripheral neurolysis, or radiofrequency ablation, vertebroplasty or kyphoplasty, intrathecal drug delivery systems, and advanced procedures are neuraxial neurolysis, pituitary ablation, anterior cordotomy, spinal cord or DRG, peripheral nerve stimulation. Now we should focus on some morphine, which is commonly used drug for cancer pain. The starting or usual dose of morphine is a 10 mg 4 hourly. In frail, old and renal issues, we can decrease the dose 5 mg 4 hourly. Watch response for 24 hours and then step off if required. If patient is getting less than 50% relief, then increase the total daily dose by 1/6. Means if the first day patient is taking 60 mg and if the patient is not getting relief more than 50%, then we should increase again 1/6 of that 60 mg, means 10 mg. If we get a positive response, mean more than 50% relief, if 2 weeks on 4 hourly dosing with positive response, then we should shift the patient on sustained release formulation at 12 hourly basis. In morphine, we are immediate release, the sustained release formula available in the market in oral form. We should start with the immediate release tablets, and after 2 weeks of more than 50% relief, then we should proceed. We should shift that patient on sustained release formulation. No tolerance develops to constipation and meiosis. Constipation due to hypomotility. The drug of choice for this hypomotility caused by morphine is bisacodyl or metoclopramide. What is the equivalence to morphine? Morphine 60 mg per day if we are giving, it is equal to 600 microgram per day of fentanyl, and it's equal to 25 mic fentanyl patch. If 1 mg of intrathecal morphine we are giving, it means we are giving 10 mg of epidural morphine or 100 mg of parenteral morphine, or we need to give a 300 mg of oral morphine. These are the conversion rate. As such, when we are starting treatment on oral medication and if the patient didn't get relief with the oral medication, we have to shift the patient from oral to parenteral, then if from parenteral to epidural and then intrathecal. These are the conversion rate with how much the requirement of the morphine on oral waste daily. From that we have to calculate the doses of the parenteral or epidural or morphine in this way. Intrathecal drug delivery system. For candidates with a life expectancy beyond 3 months, we should proceed with the intrathecal drug delivery. What are the drugs used for this purpose? We can use morphine, clonidine, bupivacaine, zinconotide, and trial of therapy. Morphine should be start with their test dose, which is 100 to 300 mic. Factors to be considered for deciding the test dose is a patient's age, it should be more than 65 years or frail. If it is opioid dependent, if less than 90 mg per day of morphine needed, then we should give a test dose. If suppose the patient is less than 65 year age and his requirement is more than 90 mg per day of morphine, then we should give a 300 mic of testing dose. If patient is more than 65 years and the daily requirement is more than 90 mg, then we should give a 200 mic. If more than 65 year and less than 90 mg requirement, then we should give a test dose of 100 mics. If patient get response after testing dose, then placebo injection we should give. If no response, then we should double the test dose But incremental dose should not be exceed 200 microgram. Maximum test dose we can give it up to 1000 mic. This is the instrument we should use for giving a intrathecal drug delivery system. This we can see the catheter is going in in subarachnoid space from the spine, and this instrument we should implant it in abdomen fat or anywhere in the abdomen, and it metered dose calculator we have to set in it, and whatever we set the dose, it slowly goes in your patient and it make the patient pain free. Morphine intrathecal daily dose. Morphine may give 0.1 to 0.5 milligram per day is the starting dose, and there are another drugs doses are also given in this chart. When we should do neurolysis for chronic abdominal pain, these are the interventions started now. Which interventions we can do for relief of the patients. This is a flank neck neurolysis. We can do this flank neck neurolysis for the chronic abdominal pain of our upper abdominal cancers. It is a AP view of a flank neck neurolysis of the spine. There is we can see the needle and the dye spread of the on the CM image. It is anterior to facetal line. We can see the dye spread in black shadow. It is in a lateral view. In lateral view, we can see the two needles on both sides and a dye spread also. And this needle tip should be at the anterior 1/3 and the posterior 2/3 of the vertebra for the release of the drug. It may be anticrural or retrocrural. After that, we can do a celiac plexus neurolysis also. It is also for the upper abdominal cancers like hepatocellular carcinoma, liver, pancreas. We can give for acute pancreatitis or chronic pancreatitis pain also celiac plexus neurolysis. This is the AP view. This plexus is a sympathetic trunk plexuses are there, and we are doing the sympathetic plexus neurolysis. Most of the pain are carried by the sympathetic pathway. This is the ganglia which lies in front of the L. We can see needle and the dye spread of the celiac plexus neurolysis. In this lateral view, we can see the dye spread anterior to the vertebra, and it's anterior to the aorta also, because in just anterior to vertebra there is a aorta, and just in front of the aorta there is a celiac plexus is situated. We can go by intra-aortic route also. We have to pierce the aorta and go beyond aorta, and then after we have to give the dye spread, and it is in a typical manner. Then we should proceed for giving the drugs. This is the celiac and splanchnic. Both blocks are given in this patient, bilateral splanchnic and celiac. Neurolysis for pelvic pain. If the pelvic malignancy is there and the patient is having pelvic pain, we should proceed for superior hypogastric neurolysis. Superior hypogastric plexus neurolysis. This is the needle we can see. In a lateral view, we can see the dye spread in front of the L5S1. This is the superior hypogastric plexus is there. See. This is also in AP view of the superior hypogastric plexus neurolysis, dye spread in front of L5S1 vertebra. It is a bilateral needle and bilateral dye spread. What drugs we use in intrathecal neurolytic? We basically use alcohol and phenol. Alcohol is an aqueous material which is a hypobaric. Its effective concentration available in market are 50 to 100%. When we give alcohol in 50%, then there is a C fiber neurolysis may occur. If it give in 75% concentration, the C fiber and sensory neurolysis occur. And when we give beyond 75%, then it cover all. It means C fibers, nociceptive fiber, sensory fiber, and motor fiber also. it complete neurolysis occur with according to the use of the percentage of the alcohol. It blocks nociceptive pain, sensory or motor. For intrathecal use, we use 100% concentration. We can use the water or local anesthetic as a diluent for it. Another one we use commonly is a phenol. It is a viscous material. It is a hyperbaric. Its effective concentration are 4 to 10%. It is again 4 to 5% concentration. It blocks the C fibers, and 5 to 6% concentration it blocks C fiber and sensory. And if more than 6% concentration we use of the phenol, it blocks everything. For intrathecal use, we can use 4 to 6% phenol. Diluent we can use for it as a glycerin or radio contrast material, which is used for dye spread. We can use as a diluent for it. As alcohol is a hypobaric, if we have to do a right sided block, we have to make the patient lie down on the opposite side, means affected side should be on upside. And when we are using phenol, because of its hyperbaricity, we have to make affected side downwards. When we use alcohol, the duration of relief, pain relief, it may be for 3 to 6 months, or sometimes it's more than that. The shelf life is more than 2 years. What is the mechanism of action of alcohol neurolytic? It causes dehydration, it causes lipid lipolysis, lipid extraction, which means demyelination, and the sclerosis of that neural tissue. Because of that, the nerve are damaged and the pain pathway are cut down. And this is the painful injection. While we are giving, patient may get pain sensation. Complication of alcohol, it may cause a neuritis. When we use phenol, it's a duration of pain relief, it may be for 1 to 3 months. Its shelf life is 1 to 2 years. Action by degradation of the protein, coagulation of protein. Whenever you give it, it is painless and patient may feel warmth. Neuritis is less common. Preferred site of use of alcohol are intrathecal, celiac plexus for lumbar sympathetic chain blocks, cranial nerve blocks, paravertebral blocks. Upper safe limit for use is a 30 gram. And phenol is preferred site user epidural, paravertebral, peripheral, intrathecal, cranial nerves. The less chances of neuritis occur because of that. It is used in peripheral nerves also. Its upper safe limit is a 1 gram. Now vertebroplasty or kyphoplasty. For these procedures, we should need the patient selection is very much important. Patients with the back pain secondary to fracture from bony metastasis or tumor with unstable spine, we should select such patients. We can give in a traumatic injury also, we can do vertebroplasty or kyphoplasty, traumatic injury of the spine. This is the image where it shows a needle. We can see a compressed vertebra in one image, and another image we are seeing a cement is going, which is in red color, which gives the strengthening to that vertebra, fractured vertebra. Vertebroplasty used to treat a painful vertebral body collapse or fracture caused by osteoporosis or tumor. Vertebroplasty and kyphoplasty both are the same procedure, except kyphoplasty help to restore the height of the vertebral body. This is the picture of vertebroplasty in which we use a cement, filling the fractured vertebra with cement through the needle, but with vertebroplasty we could not restore the height of the vertebra which is collapsed due to tumor, osteoporosis or whatever trauma. But when we use a kyphoplasty, in kyphoplasty we use central vertebral body access with a tube, and from that tube we insert the balloon inside, and after inflation of that balloon the height of the vertebra is restoring. which is not restored in vertebroplasty. In kyphoplasty, we can restore the height of the vertebra, and after the inflation of the balloon, we should fill it with the cement. And because of that, the straightening is also getting, and the proper height of the vertebra is also we are getting with the kyphoplasty procedure. Now, the radiofrequency ablation of the specific nerve or ganglion. This is a Cosman's radiofrequency ablation machine. We should use it for selective block, very high precision, and with the very minimal side effects we can use it. But the problem with this radiofrequency ablation is the cost of the procedure or machine and delay in onset of the result. For radiofrequency ablation, we can give for following conditions. If a liver carcinoma is there and less than 3 to 4 centimeter size of the tumor in it, and there are no multiple mets, we can proceed for radiofrequency ablation. In kidney tumor less than 4 centimeter, one kidney should be involved, poor surgical candidate, we should proceed for radiofrequency ablation. In lung also 3 centimeter size, up to 3 centimeter size, 1 or 2 tumors, or in bone also at 1 or 2 sites. If lesion is there, we can use RF ablation. RF ablation may cause a local tumor debulking. It is used the percutaneous guided. It is the outpatient procedure. There are no bone marrow exposure to external radiation, it may occur with the radiotherapy, or it is having a minimal side effects. These are the benefits of RF ablation, radiofrequency ablation. When we sometimes we do radiofrequency ablation intralesional, at that time we use the high frequency alternating current emitted through electrode placed within the tumor via probe. Tissue may be heated up to 113 degree for 10 to 15 minutes. It is first reported in 1990. It may be used for the cancers of the liver, lung, kidney, bone, heart, breast, adrenal. It causes cell death. Now, pituitary ablation procedure. For a metastatic carcinoma of hormone dependent tumors like breast and prostate, in LCAS of 0.1 ml up to 0.5 ml we use for doing the pituitary ablation. Cautions used during this ablation procedure are optic chiasma just above pituitary is there, we have to see that. Dura V also just above the cellular turcica, we have to save also that. And there is a possibility of the diabetic insipidus due to the pituitary ablation, because the ADA secretion is from pituitary and we are ablating that pituitary. Because of that, patient may get diabetic insipidus. Sometimes anterior RF cordotomy also may be do for the specific reasons. By doing cordotomy, we may do lateral spinal thalamic tract ablation. And this is the advanced procedure in pain management. This is a spinal cord stimulator, in which there are electrodes are there, which we have to insert in a spine according to their lead position. If suppose patient is having occipital neuralgia, we have to insert the lead at C1 C2 level. For the upper limb, we have to do C2 C5. It like the dermatomal level patterns, we have to insert the leads in the spine. And the setting we have to keep like amplitude, rate and pulse width as per the settings needed. You can see in this picture, this is a lumbar spinal cord stimulator, thoracic spinal cord stimulator. You can see electrodes placed inside thoracic level and lumbar level. These are the highest and last procedure for doing pain management, which is very advanced technique, which is very rarely used because of its cost. So today's topic is for thank you all of you for hearing my talk patiently, and thank you for Dr. Sachin and Dr. Prahlad sir for giving me chance to give this lecture. Thank you, IS in 100.
Krishna,
Huh.
there is one question in the chat box. Please
Hmm.
guide us where this alcohol for neurolysis we will get in Mumbai.
If we go any surgical shop, you can get that 100% alcohol
She
easily.
searched it, but she couldn't get it.
Otherwise, you can ask it any interventional radiologist. They can give you,
Okay. Okay.
or any pathologist also. Some pathologist also using it. They can also give them.
Any more questions someone wants to ask? Sachin? Sachin?
Hello.
Hello.
Sir, good evening, sir. I am Dr. Nityananda from Tamil Nadu.
Okay.
Sir, I want one clarification, sir. Sir, what is the procedure? How to proceed with the intrathecal alcohol, sir?
Intrathecal
Alcohol.
alcohol.
Yeah.
So actually, intrathecal alcohol is a last resort for the patients who are whose life expectancy is 1 or 2 months period,
Okay.
and they are bedridden patients. Just we have to, when we give intrathecal alcohol, it may damage the peripheral nerves, nerve roots, and it may
Okay.
damage the spinal cord. There are less chances of damaging spinal cord, but it may damage, and because of that the motor
Okay.
activity is also hampered. Because of that we use this procedure in a last resort for the bedridden patient or whose life expectancy is not beyond 1 month or 2 months.
Okay. How much volume, sir, per segment?
Per segment, as we use, I depend on the patient and what type of pain he is having and which type of cancer it is, and according to
Okay.
that we should use the concentration of the alcohol. We also use 40-50% or 70% according to the patient's tolerability and the patient's pain and how much can sustain it.
Okay. Sir, if a patient having a see a breast with axillary metastasis with inoperable cases, can we use that for
adrenal
thoracic segment, sir?
adrenal metastasis.
No, sir. For a breast CA, inoperable,
Huh? Huh?
the fungating growth, can we use that for in the thoracic segment, sir? Also?
Actually, in thoracic segment, we avoid it. We generally give it in the lumbar segment. Preferably, I practice it.
Okay.
And if life expectancy is not more than that, you should avoid in thoracic segment alcohol.
Okay. Okay. Right.
You should go for stellate ganglia block for the CA breast.
Okay.
You use first local anesthetic plus steroid as a diagnostic block. Then after you can do RF ablation of stellate also.
Krishna,
Or
come. Can you on your video? Our presentation is
I
over, I think.
couldn't I couldn't
You just exit from the. Yes, yes, yes. You exit from your screen sharing.
yeah, but I didn't
Back
getting
to.
that
Yes.
I
You
am
exit
didn't
from your
getting
screen
that.
sharing and join to Google Meet. Yes. On your video.
I am not getting that link. That presentation is coming only.
Gmail.
Yeah, yeah.
That video wala icon. On your video. Yes, yes.
Yes.
Kotkar sir, please pin him. Kotkar sir.
करतोय.
Okay, हाँ चलो हो गया. Continue Krishna.
Okay. Is there any question?
There is one question from Dr. Varsha Suryavanshi in chat box. Can you read?
1 minute.
Sachin,
Uh,
that question is answered.
okay. I don't know that thing. Okay.
I couldn't
Any
see the
question
chat
from
box
audience?
here.
Hello, Balraj.
Balraj mute.
Yes, Balraj. Make you unmute. Okay. I think no questions from audience, Krishna.
Okay.
Karuna Patil madam. Balraj,
No,
you go for vote of thanks. Okay. Then we will
okay.
conclude the session.
Krishna sir, presentation was very nice. I am thankful for Krishna sir presenting this beautiful presentation on behalf of ISA Nanded. Thank you everyone for joining this Google Meet.
Thank you.
Thank you, Balraj. Thank you, Krishna. Thank you, all of our members. Very nice
Thank you, sir.
presentation by Krishna on cancer pain management. Thanks.
Krishna
Sir,
made
off your recording, sir.
Krishna made what subject so easy.
Yes. He is a pain specialist and
The
first
record,
pain specialist in Marathwada also. So he is
yes.
always best. Sir,